and then a food slot here. And typically when the nursing staff comes by in segregation, which they're supposed to do once a day and make sure that you're okay, the conversation takes place through the food slot. And the cells are about that size.
So the long-term seclusion would be closed in that box 23 hours a day?
In that cell, yeah.
What about the restraints? What nature are the restraints used?
Are you familiar with the Pinel restraint, 5-point Pinel bed?
Strap down.
Yeah.
When needed.
Yeah.
Thank you.
I'd also like to add to that that any communication, not only with nurses, but with any chaplains or any other people that an inmate is allowed to see in segregation, also takes place through that hand slot. Even if the prisoner wants to do a Bible study, it takes place through the hand slot. And when people, you were saying if things are forced on them or not, they don't only have to deal with what's being done to them at the present time. They have to accept it because of the fear of retaliation, which is extremely high in prisons, even by a recent newspaper article stated by a judge, even though it wasn't her jurisdiction in the complaint, but she realizes that the retaliation on offenders is extremely high. Yeah. And that's something that they really have to consider.
Yeah. One of the issues with surviving with a mental health challenge in a prison is also your fellow inmates, because that behavior that's disruptive, perhaps to the order of the institution, is also disruptive to your cellmates or to the other people on your wing, and so that also sometimes results in moves to segregation, because other inmates have said, you know, move this guy, because we can't sleep when he behaves the way he behaves all night, or whatever the case may be.
Yeah, I was just wondering if there's, when people are being moved or they're in court or whatever, if they're giving them sedatives as opposed to antipsychotics or stuff like that, if you're seeing that.
Yeah, it varies. I mean, I was in one institution the other day, and I was talking to the head of healthcare, and I asked, can you tell me what percentage of the population today would be on psychotropic medication? And she said, pardon? I said, well, what percentage, you know, how many guys are taking pills, you know, because of mood or diagnosis of an Axis 1 disorder or whatever? And she said, well, I think there might be like a couple dozen that aren't. But the use of medications inside the prison is substantial, and I'm beginning to get a better handle on drug use, prescription drug use inside federal penitentiaries by looking at just the dollar volume, and I'm now beginning to break it out by region and by institution, because there's huge differences, there's huge variation across the country. So in some parts of this country, you'll see a tremendous reliance on antipsychotics to a much higher extent for a similar population in another part of the country. So I'm trying to get a handle on why that is.
I've emailed your office this information, but I don't know if it's gotten through to you, but in Mission Institution, which you know is a low, medium security institution, I was shocked to hear how the medication is given out. The inmate is given a card with what their medication is, and they take it to the window, they pick up their medication. They can do what they want with that medication once they've got it. They can save it, they can sell it, they can give it away, they've got it. And I mean, I just think it's a matter of time before somebody's going to either die of an overdose, suicide, or mix medications that are not meant to be mixed. I was shocked when I heard that the medication is just floating around once they've got it.
And that again, it varies by offender and it varies by institution. But managing that inside a penitentiary is very difficult. And I've gone through wings of some penitentiaries and gone in at the invitation of some of the guys, and we've sat down and we've talked, and I look over and I'll say, so what are you saving it for? And they've got a whole stack of their pill packs, and I mean it presents challenges. You first, and then you.
A question: as you're looking at the different pens and medications, I wonder if one thing your service is looking at is tying it to pharmaceutical lunches and presentations and things like that. Because I'm actually a psychiatric social worker, and so a lot of the pharmaceuticals, they will sponsor like rounds, and so just wondering if there's some, when you're seeing those different, numbers of medication.
Yeah, no, we're just beginning, and we haven't gotten anywhere near that yet.
Just an area to play.
But it's,
start to look at those patterns.
It's interesting how even TV ads, people ask for stuff all of a sudden.
There is no free lunch, and so there's something to look at.
Could we hear the rest of your presentation and have the questions and comments later?
I'm finding this really therapeutic, though.
You're enjoying it.
I'm almost done, but thank you. I just haven't, had a chance to actually talk to people for a while. So I'm almost done, coincidentally. The annual report that's pictured there is right here. It was just released publicly on November the 1st, so it's just a couple of days off the press. It was tabled in Parliament, even though you'll see the letter was written June 29th. The legislation requires that I present my report, which is April 1st to March 31st. By June 30th every year, so you see I just got in under the wire. So on June 29th, I gave my report to the minister, and the minister is legally obliged to table it in Parliament within 30 sitting days of Parliament. So 30 sitting days, if you give somebody something in the middle of the summer when Parliament isn't sitting, the clock doesn't start until they do sit. And we've had so many elections in the last little while that I've actually had my reports almost backed up, So the drop dead date on this report was November the 4th, so the government actually got in well ahead of time by tabling it on November 1st. But there it is. I've got a couple of copies with me here. There's a couple of hard copies and a couple of disc copies, so if any of you are interested, you please feel free to take those. And I'm going to show you in a minute our website address. And if you go to our website, electronic versions of this report are also available, as well as any of our previous reports and some of these public interest reports that we've issued as well on mental health, deaths in custody, and a couple of other things as well. And I think we might have even migrated to our new website. Which I'm really proud of because it actually looks like it was done this century. So, it might be live. I'm not entirely sure. But we've in this latest report, there's a number of recommendations. Probably the largest area of recommendation regarding mental health is that we're encouraging the Correctional Service of Canada to accelerate its discussions with healthcare providers, particularly provincial and territorial healthcare providers, to actually meet the healthcare needs of inmates, as opposed to being the actual provider themselves. The law requires, federally sentenced offenders are not covered under the Canada Health Act, right? The federal government is responsible for the provision of healthcare to certain groups of Canadians, and federally sentenced offenders are one of those groups. What we're encouraging the Correctional Service of Canada to do is to stop thinking of itself as the healthcare provider, and for instead think of themselves as the healthcare purchaser, and work more closely with provinces and territories. We think there's lots of efficiencies there. We also think that there's good news there for continuity of care, and we think it will help assist in that transition out of prison back into the community. So we've made some recommendations there. We've also made some technical recommendations. We've talked about placement of restraints for healthcare purposes should be a reportable use of force. And this is a very controversial recommendation. Remember I told you that all those use of force incidents are videotaped? And then I also told you that some of the things we've seen concern me about use of restraints being done punitively instead of for healthcare reasons. Well, what I would like to do is when placement of restraints is being medically supervised, that the placement of restraints be videotaped, so that there's the same kind of evidentiary chain, that it's being done for all the right reasons and it's not being done in a way that's punitive. We also would like to see the Correctional Service of Canada enhance its oversight and accountability for developing of clinical treatment plans for those people who chronically self-harm. It's great that they've got the complex needs unit, even with the bulletin boards, but we think that they need to put a little bit more energy into actively managing those cases. And we think that the most serious cases of self-injury should be immediately reviewed for transfer to hospital situations if it's warranted. Try to get a better handle on where the self-harming behavior is coming from. So, more details about those and some of the other areas that we've reported on this year are available in the annual report. You can either get a copy or you can check our website. A little bit of good news, I think, to end with, and that is, in the last couple of years, there's been a renewed focus on mental health in corrections. That's a good thing. I've met with each of the last 4 ministers of public safety and ministers of justice and federal ministers of health to discuss this intersection, this nexus between mental health and corrections. There is a working group of officials dealing with a national strategy for mental health and corrections. The heads of corrections have made mental health a priority, and the ministers responsible for corrections have recently renewed their commitment to making mental health a standing item on their agenda every time they meet. So there's been lots of political and organizational bureaucratic attention paid to this issue in terms of developing and then implementing a national strategy to coordinate responses and better share information when we're dealing with mental health and corrections. The Mental Health Commission of Canada has played and continues to play an important role in the development of that strategy. And so I'm hopeful that that we'll see, maybe a year from now, 2 years from now, if I'm invited back, that lessons learned and the slide and the one about new investments, maybe it'll be 2 or 3 more slides. I'm hopeful that some other good things are going to happen. In the meantime, don't think it's enough to rely on corrections to deal with what is at its root a health issue.